Hello and welcome to our live event tonight. It's 8 p.m. UK time. Therefore, as always, it's time to start our webinar. And I am very happy and excited to be back here with Professor Luciano Nardo. Hi, Professor Nardo. How are you feeling today?
I'm very good, thank you. Good evening. Good evening to you, and good evening to everyone listening to us.
Yes, thank you so much. And of course, as you can see, we do have a very interesting and a very important topic today to discuss, and it is egg freezing indications, limits, outcomes, and costs in the UK. So, this is, I think, in my opinion, this is a topic that should be spread out more and more often. So, I'm very, very happy to be back here with you, Professor Nardo, and of course, present this topic to all of you. Before we start, let me just simply explain how everything works so that you know. So we will simply start with the presentation. After that, it will be time for your questions. So anything that you have in mind, just go ahead and type the questions in the chat section. And then, of course, Professor Nardo will be answering them for you one by one. So don't miss that opportunity. And of course, as always, let me remind you that this is being recorded, so you will have a chance to also re-watch it. And I also want to mention that Professor Nardo is a clinical director at Reproductive Health Group, which is located in Manchester, in the UK. And this is not our first webinar together, so I am even more happy that you decided to come back and present some of the topics. This is our first webinar with you this September, but definitely there will be more of those coming up. So already I would like to thank you for joining us again and for being with us today. And are you ready to start with your presentation?
Yeah, absolutely fine. Yeah, I'm ready. Thank you.
Excellent. Thank you so much then, and go ahead.
Okay, so again, good evening, everyone, and thanks to IVF Media for giving me the opportunity to present on this topic tonight. I think we well know that egg freezing has been a matter of much debate amongst professionals, but also in the media and in, in the public eye. And the reason being that has been seen perhaps as a kind of insurance to preserve fertility. I will be discussing tonight the indications as well as the limits and the risks, the outcomes, and finally the costs of egg freezing. Various medical, ethical, and social reasons have been put forward for egg freezing. And in the last 25 years, scientists and clinicians have worked together in order to optimize the laboratory and clinical protocols for egg freezing. And it is worthwhile noting at this stage that the first human birth from cryopreserved eggs was reported in 1986. So this is actually not a novel procedure. And if you remember from previous webinars, which you may have listened to, IVF was first using in clinical practice in mid 70s. So the cryopreservation of eggs being dated about a decade after the first successful IVF treatment is actually makes it not certainly a recent procedure. Various studies have looked at fertility outcomes using egg freezing, and I will be discussing with you the evidence as well as my professional and expert opinion regarding the freezing technique. And various studies have also looked at the outcomes of fresh versus frozen oocytes, and I will be also presenting on the most recent data. The American Society for Reproductive Medicine found that elective egg freezing is to be considered ethically permissible, as is known to enhance reproductive autonomy, but also promote social equality. However, in my opinion, and in the opinion of other healthcare professionals and fertility physicians like me, it should not be used as a form of reproductive insurance. And the reason being is that many women should not be led towards a path that may not be correct, as we all know that an insurance is to some extent a guarantee that if something goes wrong, then there will be a solution. And the reason why it cannot be considered a form of reproductive insurance is because there is no guarantee, irrespective of the total number of cryopreserved eggs, that those eggs will fertilize successfully, and more importantly, will give will lead to a successful pregnancy outcome. The benefits of egg freezing are not dissimilar to what some healthcare professionals have identified in the cryopreservation of blood cells, the storage of tissue to treat possible future health issues. Individuals freezing eggs are healthy individuals at the time of the intervention, so that is the time of egg cryopreservation. It is an established procedure. The first live birth was over 30 years ago, and to some extent helps to avoid or reduce the need for egg donation at a later stage. But what is egg freezing recommended for? So there are various indications, and the topic tonight will focus predominantly on the use of egg freezing for social reasons. So I'm not going to discuss the medical indications that are well known, for which egg donation is well established. So for instance, for cryopreservation of eggs in cancer patients, I'm not going to discuss about the use of egg donation for of egg freezing for egg donation as part of egg banks. One of the, I think, most established concepts of cryopreserving eggs lies with delaying pregnancy. And women in this day and age choose to delay pregnancy for various reasons. Could be demographic, could be workplace factors, could be a lack of partner, but could also be the rising costs of childbearing. And this very interesting paper published in Fertility and Sterility, which is the American Journal of the Society for Reproductive Medicine, shows that some women have heard about egg donation from friends, some have heard from a physician, some may have become familiar with egg freezing because of an advert played on a TV or magazines, or may have had some sort of contact with information that was sent to them on social media, but may also have become more familiar with the concept of egg freezing because of information that is available on the internet. And the reasons for choosing to freeze eggs in 88% of cases was down to the lack of partner, which means lack of a stable relationship. So this is quite interesting because more than 3/4 of women that were assessed at the time, they decided that freezing their eggs was going to provide them with some kind of comfort rather than rushing into a relationship. And it is established that oocyte freezing technology bridges the gap between reproductive prime, which is when there is the best possible chance of achieving a successful, healthy pregnancy, and when the woman is ready to start a family. And what is the likelihood of women using their eggs? Again, the same paper shows that only 6% of women that had cryopreserved their eggs say that it would be very unlikely to use their eggs. 34% said actually it's very likely that they will be using their eggs, and 60% commented on being somewhat likely. So overall, over 90% of the population studied confirmed that they will be using their eggs. However, we all have to be familiar with the limitations and the risks of such an established procedure. Chronological age, and that is both for storage of eggs as well as for pregnancy. I will be discussing in more details the importance of cryopreserving eggs at a young age. And we know that women that cryopreserve eggs after the age of 35 are likely to have poor quality eggs. Hence, they should be very well prepared and counseled about the limitations of egg freezing. Ovarian reserve. Chronological age per se is not the only determining factor when it comes to fertility potential. The other one being the woman's ovarian reserve. So both high ovarian reserve is a risk because of hyperstimulation syndrome. Low ovarian reserve is the other risk at the opposite side of the spectrum, with very poor response, possibly no eggs, or perhaps poor quality eggs may not survive the freezing process, or at a later stage, the thawing and in vitro fertilization by ICSI process. We also are aware that women embarking on egg freezing may experience anxiety, especially if they do embark on this process on their own. Hence why they would be freezing their eggs, because they're not in a relationship. There are some risks also with the procedure to harvest the eggs, although the risks are very, very slim. Risk of infection, risk of bleeding, risk of injury to nearby organs and vessels, such as the bowel or the bladder. There are also some very slim risks with sedation and anesthesia. However, on a positive note, there is evidence coming from this publication that the use of egg freezing and the use of eggs that had been previously cryopreserved does not increase adverse pregnancy problems, does not increase maternal or fetal problems. There is, however, as we discussed before, a close relationship between the age when the eggs were cryopreserved and the probability of live birth. And I'm going to discuss this in a little more details now, but I would like our audience tonight to be in line with what actually evidence is at the moment, that the use of egg freezing as a technique to cryopreserve fertility should ideally be recommended to women under the age of 35. And the reason being is that with advancing chronological age, there's going to be a lower cohort, a smaller cohort of follicles, and the follicles that reach the stage of cyclic recruitment, known as antral follicles, may become less sensitive to the stimulation. So in order to maximize the chance of success of the egg freezing procedure, chronological age as well as satisfactory ovarian reserve are very important. And how we assess ovarian reserve, I think is simple. That can be done either by a blood test for AMH or by doing a transvaginal ultrasound scan at the beginning of the cycle and look for the number of antral follicles. Now, that is follicles measured between 2 and 6 millimeters present in the ovaries. And we've seen in this publication coming from a group that both AMH and antral follicle count correlate very well. They're good markers of ovarian reserve. So women should consider having their ovarian reserve checked irrespective of their chronological age by either having a blood test for AMH or an ultrasound scan for antral follicle count prior to embarking on treatment. Knowledge of the ovarian reserve will also assist in making a well-informed decision. And what I say to all my patients is that whatever we do, we need to bear in mind that the treatment is going to optimize the endogenous conditions. So it's going to provide the optimum environment for follicles to grow and for eggs to mature, maximize the chances of the treatment being successful, which means collecting mature eggs that can be cryopreserved and at a later stage survive and be suitable for in vitro fertilization, and indeed minimize the risks as well as minimize the disappointment. The topic I'm going to touch on very briefly is about the techniques used to cryopreserve oocytes. For a very long time, embryos and also eggs were frozen using a technique called slow freezing. And the use of slow freezing had been shown to increase the damage to the cells. Whereas the use of the more recent technique known as vitrification has been shown to maintain the structural integrity as well as the biological viability of the cells. So this is very important. And I'm going to present to you, I'm going to share with you some information comparing the use of slow freezing with vitrification. We presented a paper a number of years ago at the European Society of Human Reproduction meeting, and that came from a publication that myself and colleagues did a number of years ago. And we looked at the literature, and what we wanted to see was whether there was any potential disadvantage of using wormed oocytes compared to fresh oocytes. And we looked at eggs that had been vitrified. And what we found out that the fertilization rate per egg, per oocyte, comparing fresh with frozen by vitrification oocytes, was very much the same. We also looked at the clinical pregnancy rate, and we separated the studies that used donor eggs from the one that actually didn't use donor eggs. And you can see in the first part of this graph, the studies that used donor eggs, there was no difference whatsoever, showing that if we're using egg from young, healthy, fertile women, freezing the eggs is not affecting the quality of the eggs and indeed the chance of clinical pregnancy. If instead we look at the non-donor oocyte studies, you can see that there is a tendency towards fresh oocyte being better than frozen oocyte in terms of clinical pregnancy rate. And this is predominantly down to the quality of the eggs. And that is linked with the chronological age of the woman. Putting all the data together, so the studies that looked at donor eggs and the one that looked at non-donor eggs, then we can conclude, or we concluded at the time, that there was not a statistically significant difference in terms of clinical pregnancy rate between fresh and frozen eggs. Another study concluded that intermediate outcomes such as oocyte survival rate, fertilization rate, and embryo quality appear to be higher with vitrification compared with slow freezing. And this publication, comparing the slow freezing with the vitrification, quite clearly and elegantly shows the benefit of vitrification over slow freezing. We can see that the percentage of high quality embryos with the vitrification compared to slow freezing is significantly higher. We can see that the number of oocytes that survive again is higher with vitrification at 91.8% compared to slow freezing that being at 61%. And looking also at the percentage of oocytes with abnormalities and comparing that to a control group, we can see that vitrification is very similar to the control group. So only 17% of oocytes had abnormalities with vitrification compared to 39% of oocytes with slow freezing. My next slide looks at the egg versus embryo vitrification for delayed embryo transfer. And this paper shows that they produce exactly the same live birth rate. So in a good lab with good technology, with established techniques, with a good operator, freezing eggs will lead to the same live birth rate as freezing embryos. This study is instead looking at the cumulative ongoing pregnancy rate achieved with oocyte vitrification and cleavage stage transfer, which means embryo transfer of embryos on day 2 or day 3. And what we can see, just in the benefit of me summarizing this study for you, is that there is no statistically significant difference. So if you look here, the only difference that becomes obvious is according to female chronological age. You can see that the implantation rate using cryopreserved oocyte is about 30% in women under the age of 34, but is 18% in women over the age of 38, and it's only 9% in women aged 31 and older. The clinical pregnancy rate is 45.9% in women under the age of 34, and is less than half in women of the age of 31. And as expected, the miscarriage rate increases with maternal age. The clinical outcome, according to the oocyte, comparing frozen oocytes with fresh oocytes, is very much the same. And this is coming from probably one of the most established laboratories in Europe. And they looked at the use of cryopreserved eggs in an egg donation program. That means that a recipient used either frozen eggs or fresh eggs in egg donation program, and the clinical pregnancy rate for frozen eggs and for fresh eggs was very similar. The ongoing pregnancy rate, based on the intention to treat, was again the same between the egg bank, so cryopreserved eggs using vitrification and fresh eggs. And looking at the study that assessed the performance of egg freezing in 7 different clinics across the United States that were identified as being egg banks, shows that 6 out of the 7 egg banks used vitrification, and the majority of the egg banks would recommend the use of 6 oocytes to women embarking on an egg donation cycle to achieve the best possible outcome. Finally, this prospective control study looks at the laboratory and also the clinical outcomes of oocyte vitrification. And what we can see that there are 2 age groups, age 30 to 36 and 37 to 39. The clinical pregnancy rate in the age group 30 to 36 is 63.6% compared to 27.3% in the advanced age group. The implantation rate, again, is significantly higher in the young age group as compared to the advanced age group. This shouldn't come with much surprise because, as I would like to show you in this slide, we know that fertility declines with age. We know that the number of good quality eggs declines with age. So over the age of 35, we are just past the best fertility stage. We are in the declining fertility phase of life, which has a significant impact on egg quality. And this slide just again is to reinforce what I've just said, that the probability of live birth with oocyte cryopreservation depends on chronological age. And when we look at this other publication, again in Fertility and Sterility, which is the Journal of the American Society for Reproductive Medicine, what we see is on the left-hand side, the age of the patient. On the right-hand side is the survival of eggs. And the survival rate of cryopreserved eggs is higher as younger is the chronological age. Finally, I will touch on the cost for egg freezing, but also we need to bear the cost for the women if they were not to embark on egg freezing now, may decide at a later stage to have a family and may need egg donation, and indeed the cost for the society. The cost for egg freezing at our clinic are as presented in this slide. The egg freezing program costs £3,450. There is an initial consultation cost of £240, which is waived for all the booking coming through IVF media. There is also a storage fee of £300, which again is waived for all the booking coming via IVF media. The cost of the medications depend on the ovarian reserve and not just the chronological age, and vary between £1,000 and £1,750. So, in conclusion, egg freezing is a realistic approach to preserve fertility, and in my opinion provides women who are not in a position to start a family now with at least an opportunity to mitigate the inevitable decline of fertility with advancing chronological age. However, women undergoing egg freezing should be made fully aware by the healthcare professionals, fertility physicians, of the likelihood of success, as well as the costs and the risks, as presented in these slides. Underlying ovarian performance is a very important determining factor. Age is the other important factor. So 35 years is probably the cutoff point to provide the best chance of success of the egg freezing program. Vitrification of eggs shows a significantly higher performance than slow freezing protocols. Vitrification causes less damage to the eggs. Egg freezing is an effective approach also for egg donation cycles. And I sincerely hope that I made it clear that fertilization, implantation, and clinical pregnancy rates are very similar for fresh and cryopreserved by vitrification eggs. It is also known that egg freezing is safe, and I showed you the publication to support the statement that the use of frozen eggs does not increase the risk of obstetric and perinatal problems. However, at the present time in the UK, younger women may be disadvantaged by the current legislation because currently the storage period is 10 years. So women that are 25 or 27, 28, that decide to freeze their eggs, at this present time, they can freeze their eggs only for 10 years. This is completely wrong. This is something that should be changed, and something that many healthcare professionals, many fertility physicians, many fertility clinics in the UK are trying to change. And I think the time will come, hopefully very soon, when the storage period for eggs will be exactly the same as the storage period for sperm, and the 10 years period of storage will go. Thank you very much for your attention. If you have any questions and you don't feel like asking them in the context of this webinar, please take note of my email address and feel free to email me later on. I will be just too happy to answer. Thank you very much. Thanks, Caroline.
Wonderful. Thank you so much for your presentation. As always, it's thorough and lots of details. So huge thanks for that. And well, it is definitely time to answer some questions, right, Dr. Nardo? So we do have some questions ready. So let's go ahead with the very first one. All right. So here's the first question that we have. How many eggs do you recommend to freeze, and is one cycle of egg freezing enough?
Well, there is no recommendation, there's no evidence of how many eggs you should be freezing. However, the data published in the literature um, in relation to the number of oocytes to be used to achieve a successful pregnancy via IVF suggests that perhaps between 12 and 15 eggs is the optimum number. Obviously, that refers to fresh eggs. If you take into account that with vitrification and depending on age, probably between 80 and 90% of eggs will survive the freezing and thawing process, then in my opinion, a safe number of eggs to be cryopreserved will be probably around 20. If that number can be achieved through one cycle, then that's great. But sometimes, I would say in most cases, to avoid the risk of ovarian hyperstimulation syndrome, perhaps that number of mature oocytes is achieved in a couple of cycles.
And excellent. Thank you so much for your question and, of course, your help with this very first question. And well, let's go ahead with the next one. I am 38 and due to try for eggs this year. Realistically, am I wasting my time?
It is not a matter of wasting time or wasting money. It's a matter of you being informed. I would suggest that first of all, you assess your ovarian reserve by having an AMH and perhaps also an ultrasound scan for antral follicle count to see how in relation to your chronological age, how your biological age is, how your ovaries work. And you need to be aware that because of your age, you may need to have, if you embark on egg freezing, perhaps more than one cycle, and realistically, more than the 20 eggs that I was referring to earlier on. Because some of these eggs that may be mature at the time of freezing may not survive, may not fertilize, and some may not become healthy embryos. So it is not a matter of wasting time or wasting money, it's a matter of knowing what the chances of success are and knowing that age per se is a limitation, but not a contraindication.
And wonderful. Thank you so much once more for your question and, of course, your assistance with this particular question as well. And let me have a look. Of course, there are more questions coming up. Next one is right here. We need to use donor eggs and are torn between doing a fresh cycle and using egg bank. Frozen eggs require ICSI, but fresh eggs can use normal IVF. Is that correct? Is using the IVF a more natural selection process for an embryo to develop?
Yeah, it is correct. If you use frozen eggs, you need to have ICSI because the membrane on the outside of the egg is thick and will not allow the sperm to swim inside easily. So ICSI is required to fertilize frozen and defrosted or thawed eggs. IVF is deemed to be a more natural form of fertilization because the best sperm will be swimming inside the egg. However, there is no evidence and there is no study to demonstrate in a comparison between ICSI with frozen eggs and IVF with fresh eggs, both coming from donor eggs, that one is superior to the other one. And I showed you the data from one of the best cryobanks in Europe, showing that actually there's no difference whatsoever in the pregnancy outcome using fresh or frozen eggs.
And once more, thank you so much for your question and again for your answer. And more questions are coming up, so let's get to the next one. Is there an equivalent to egg washing process as with sperm washing when it comes to egg retrieval and freezing process?
I'm not entirely sure about egg what the relationship with egg washing. We're not washing the eggs. And after egg collection, the eggs are put in a plastic dish, and embryologists in the lab normally they will be assessing the eggs a few hours after collection to preserve only those eggs that are mature. So eggs are put in culture media for a couple of hours after a collection, and then at that stage they are preserved only if mature.
All right, again, thank you so much for that clarification. And let's have a look at the next question. It is a bit longer one. Let's have a look then. There are some programs that offer guarantee embryos from buying vitrified oocytes which have been PGD tested as well as undergone the comprehensive 600 panel of genetic carrier diseases. Would the success rate be the same as the statistics you mentioned in your presentation, or better if they are transferred to a very good surrogate who has already had her own healthy child?
Um, I think yes, the statistics are the same, provided you have good quality embryos and the embryos come from a healthy donor um, that has been genetically tested and possibly has got her own healthy children, then the chance of success will be exactly the same. The surrogate obviously plays a role, and I think some investigations will have to be carried out on the surrogate, especially if things have changed since she has had her own healthy child. But I would not suggest that because you're using or intending to use frozen eggs, you will have a significantly lower chance of success.
All right, of course, this is like additional information, okay? But there is one more question from the very same patient, so let's have a look at it, okay? So what is your opinion regarding good PGD 424 tested embryos to be transferred to a healthy surrogate? Should the surrogate still do, um, I'm not sure, sorry, to make sure the baby is growing well without problems? What might be potential problems later in the pregnancy?
No, okay. So the question is, if we got healthy, genetically competent, genetically normal embryos coming from a donor that has got her own children, should the recipient have the prenatal genetic test known as amniocentesis to make sure that the fetus is normal? No, that's not needed. If the embryos have been genetically tested, irrespective of coming from a donor or not, from fresh or frozen eggs, then there is no need to do an invasive test that increases the risk of miscarriage, such as the amniocentesis.
All right. Thank you so much once again for answering that question. And of course, Angela, thank you so much for your question and clarification as well, of course. Excellent. And let's have a look at more questions. So, next one is up here. Hi, you said the cutoff of freezing egg is 35. Can you freeze egg for a 41-year-old woman with good AMH?
Yeah, I think I've already answered this in the context of another question. It is possible. age is not a contraindication, it's just a limitation. You can freeze your eggs if you're over the age of 35. If you have a good AMH, that is a bonus, but we know that a good AMH does not guarantee normal healthy eggs. But you need to be aware that chronologically, you will be determining the fate of the eggs by simply preserving eggs at the time in your life when you have already passed the best fertility potential. So yes, you can. It's good that you got an AMH, but you will have a lower chance of success, as I presented in my slides, compared to somebody who is younger than the age of 35.
Oh, of course, understood perfectly. Thank you so much again for your question. Let's have a look. Okay, next one. I am 43. Could you please explain again the live birth rates with over 35-year-old eggs?
Well, the live birth rate and the pregnancy outcomes overall are twice as high in someone who is under 35 as somebody who is over 35. And the chances in your age group, so over the age of 31, are probably 1 in 4 of what would be in someone who's under the age of 35. So I should see that it's probably going to be around 10% compared to being around 30-50% in somebody who's under the age of 35. So it is still possible. It's not something I would recommend to freeze eggs at your age. But if you have a good ovarian reserve, probably you will need several cycles of stimulation, egg collection, and egg freezing to collect and cryopreserve 20 to 25 oocytes.
All right, thank you once again for this. And there are like two questions left, of course. So let me just remind everyone that if you would like to ask any more questions, just go ahead and type those in. And of course, I'm sure Dr. Nardo will be happy to answer them for you. And let's have a look, okay, at the next question. So how many, you have mentioned this, but how many eggs would you ideally like to freeze for an older woman?
I think the number of eggs to freeze for an older woman will be higher than the number of eggs would be freezing a younger woman, simply because we know that not all eggs will survive, and not all eggs will fertilize, and not all eggs will form healthy normal embryos. So just to give you an indication that if you were to freeze 20 eggs for someone who's under the age of 35, probably you're looking at freezing twice the number of eggs in someone who's over the age of 35. But the problem is whether actually you're going to get that number of eggs, and whether that number of eggs is realistic based on how many cycles of stimulation and egg collection the woman will require.
All right, again, thank you so much for clarifying this question. And at least at the moment, it looks like this would be like our last question. So again, this is something you have already mentioned, but if you could have a look, how many embryos would you expect from 10 frozen eggs if someone froze their eggs at 33?
We're talking about blastocyst, and that which will be day 5 or day 6 embryos. I would probably expect at least 3 good quality blastocysts.
Okay, excellent. And I guess, of course, if everything else is okay as well, right?
Sorry, Caroline, I missed it. What did you say?
It's okay. I mean, if everything is okay, for example, with the partner, yeah, then you would
Yeah,
expect 3 good embers.
yeah, of course, yeah, absolutely.
Excellent. Thank you so much. And we can wait a bit and see if there are any other questions. If not, we will be finishing for today. But I have like additional question if you could answer. Well, in recent years, have you seen the increase? The women are actually more and more often decide to freeze their eggs. Have you seen any change in recent years?
Yeah, absolutely. We have seen and we continue to see an increased number of women under the age of 35 freezing their eggs. So there is indeed far more knowledge about the process. There is, I think, more openness about talking about egg freezing. And women in this day and age are becoming very much career focused. Although the focus has changed because of COVID-19 in the last 6 months. Um, but women are becoming more aware of the possibility to freeze their eggs, with the possibility to use them at a later stage if required, instead of having to potentially embark on egg donation.
All right, that's really good to hear that it's getting a little bit, I would say, the word is spread and more women are aware and they know that there are options. So that's great. Thank you so much for answering my additional question. And actually, in the meantime, we did receive another some other questions. So let's have a look at the next one. What are the risks of egg freezing when a woman has AIDS or other infectious disease?
I think the risk of cross contamination, that those are the risks. There are no risks per se, um, and is the same as treating women that are viral positive in a heterosexual relationship or homosexual relationship and fertilizing the eggs as fresh. So the risks are exactly the same. In the UK, the treatment can only be undertaken in some units with a specific viral positive lab. But again, it's not a contraindication to egg freezing.
All right, again, thank you so much for this once more. And there's another question. Can you increase your chances of success with lifestyle diet changes?
Yeah, absolutely. Anything that will help your general well-being will increase your chance of success. But I want to be absolutely clear in this context that adopting a healthy lifestyle, changing diet, nutrition, exercise, normal body mass index, non-smoking, no alcohol, they're not going to be changing the biological clock. I'm afraid adopting the best possible lifestyle at the age of 32, 33 may improve the, things, but in 10 years later, is not going to rewind the biological clock. So the chance of success are going to be pretty much the same. Probably there's going to be a slight benefit in pregnancy, but I would not be saying that healthy women that are over the age of 35 have a significantly better chance of success as compared to women that may be not as healthy.
Okay, understood once again. Thank you so much for your question and, of course, your answer to that. And let's have a look. There are like two questions left. So let's go ahead with the next one. Can you do egg freezing cycles straight after one, or do you have to wait?
Yeah, you can do it, and we do in our clinic. We do it. We have had patients having two up to three egg freezing cycles back to back, and in fact, there is some evidence to suggest, especially in women with reduced ovarian reserve, that the ongoing stimulation of the ovaries may have a cumulative positive effect.
All right, excellent again. Thank you so much. And well, again, it looks like this is our final question. Okay, so if you have any left, this will be like the final call for those questions. So go ahead and type those in. And the question is here: at the age of 43, not having the best AMH, is it responsible trying still to have my own child with IVF?
It is not irresponsible at all. I don't think that being responsible or irresponsible um, comes down to the age or the AMH levels. It's a choice, um, but you have to be prepared to accept a higher chance of negative outcome um, as compared to someone who's younger. You can have your own child with IVF. We have had many women of your age with low AMH, with normal AMH for the age, having a successful pregnancy outcome. So I would not say it is irresponsible. It's just knowing the limitations and have realistic expectations.
All right, of course, understood. Once more, thank you for this. And in the meantime, another question has shown up right here. Are there any side effects of having egg freezing cycles back to back, like hyperstimulation?
No, there's no risk of hyperstimulation, provided the ovarian stimulation cycle is carefully monitored and the dose of medications is selected and tailored to the underlying factors such as age and ovarian reserve. So there is no risk of hyperstimulation.
Perfect. Thank you so much once more for your question. And one more right here. Are there any limitations for egg freezing in cases of women that suffer from mental disorders or, for example, Turner syndrome?
There are no limitations. It's just a matter of for mental disorders is obviously receiving adequate support and implications counseling. So making sure that there is a good understanding of the process and more importantly, that the patient has good support at home. With regard to Turner syndrome is making sure that there is a satisfactory ovarian reserve and knowing that there might not be any eggs suitable for um, harvesting, or there may not be eggs that, if harvested, are suitable for um, fertilization. So it's not itself a limitation, it's just an underlying genetic disorder that impacts significantly on the fertility and the reproductive potential of a woman.
And excellent. Again, thank you so much for your question. And someone is typing, so I want to give it a minute to make sure that we have a shout out or a question. And well, it looks like this was our last question, but I just want to remind everyone that if you would like to ask any questions, you can contact Dr. Nardo directly. Of course, he has provided you the email in his presentation, but also you can use this link. And of course, there is an option for you to ask your questions directly to Professor Nardo and his team, and I'm sure they will be more than happy to help you out. And of course, I do believe it was very, very useful. Professor Nardo, thank you so much for joining us tonight. And as you can see, there are some thank yous from the patients. Excellent presentation. Thank you very much. Thanks as well from some other patients. So, is there anything you would like to add for today?
No, I just like to thank IVF Media for affording this opportunity to increase awareness about a very interesting topic. I would like to encourage women that are not in a relationship to perhaps consider egg freezing. However, before doing so, especially if older than 35, to have an ovarian reserve test. And if you have any questions, please do come back to me by email, and myself and my support clinical team will be just happy to answer. Thank you.
Perfect. Thank you so much to all of you for joining us over and over again. And I just want to mention that, of course, this webinar is the first one when it comes to September, but we will be back with Professor Nardo in a month's time, and actually there will be more interesting case studies that he will mention. So stay tuned. You can already register for this particular webinar as well using the link that I will send in a minute. And of course, let me just remind everyone that there are more events coming up. We will be back on Friday, and from next Monday, we will be here every single day at 8 p.m. UK time. So stay tuned. You can go ahead and just simply register to all events that are interesting to you. Thank you so much, everyone, for joining us tonight. I will let you know that, of course, this has been recorded and you will have a chance to rewatch it. It will be available tomorrow on myivfenses.com, but also on our YouTube channel. So go ahead and subscribe. That way you will be notified when the new video is uploaded. And of course, you will know when the new events are going to happen. So again, huge thanks for joining us tonight. And Professor Nardo, it's always good to have you with us. So I am very glad that we will have a chance to have more of those events. Thank you so much. Have a lovely and relaxing evening, all of you as well. And well, till the next time. Thank you so much.
Thank you very much, Caroline. Thank you, everyone. Thanks.
Thank you. Take care. Bye.
Thanks. Bye.